I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Everyone knows exercise is good for our health. New research suggests it's critical, especially for cancer patients. This is the People's Pharmacy with Terry and Joe Graydon.
Colorectal cancer is the fourth leading cause of cancer-related death in the U.S. How can exercise improve survival?
Exercise is inducing physiologic, hormonal, inflammatory, immunologic changes in the body that are helping the body eradicate a proportion of these cancer cells.
Dr. Christopher Booth has conducted groundbreaking research on incorporating a personalized physical activity program into the treatment of colorectal cancer.
Coming up on the People's Pharmacy, how exercise can help cancer patients survive and thrive.
Doctors are expected to uphold the highest standards of ethical conduct. In the Hippocratic Oath, doctors promise to put the benefit of patients first and abstain from whatever is deleterious and mischievous. A new study published in JAMA Network Open suggests that doctors who receive payments from industry are more likely to be the target of patient complaints. The researchers analyzed reports in the Patient Advocacy Reporting System Index and compared them to the physician's records of accepting non-research payments, especially those above $5,000 a year. There were nearly 72,000 physicians included in this analysis. More than two-thirds had received at least one payment, and 11% had accepted more than $5,000 in a year. 2/5 of the doctors had been the subject of unsolicited patient complaints. Comparing the two lists showed that doctors with more complaints were also more likely to be receiving significant industry payments. As the investigators note, this is associated with decreased patient trust in physicians.
A commentary accompanying the article reports that previous studies have shown a link between receiving industry payments and lower value, higher risk prescribing. It suggests, however, that this is unlikely to explain the association found in the study. Instead, it posits that doctors who are open to accepting industry payments might appear to be less responsive to patient needs. If payments actually alter physician behavior and worsen patient outcomes, that is alarming indeed.
Older Americans are very vulnerable to dying as a result of a fall. In fact, falls account for more deaths among people over 65 than breast cancer, prostate cancer, or car crashes. Over the past 30 years, the rate of deaths from falls has tripled in the U.S., although it's fallen in other high-income countries. An article in JAMA Health Forum notes that U.S. prescribing habits may be contributing to this deadly problem. The authors note that older adults in the U.S. are heavily medicated. Between 2000 and 2020, 90% of Medicare beneficiaries were taking prescription drugs. Nearly half were on medications that were considered potentially inappropriate. Many older people injured in falls were taking at least one medication that could impair balance or coordination. They include benzodiazepine-type anti-anxiety drugs, antidepressants, opioids, and gabapentinoid pain relievers. The authors conclude that 2/3 of the more than 40,000 deaths due to falls each year could be prevented if doctors were more cautious about prescribing fall risk increasing drugs.
Most people take the air quality of their home for granted, but a new study shows that purifying air in the home can lower blood pressure. The study recruited 154 adults living near highways. The researchers provided either HEPA air purifiers or identical appearing sham air purifiers. The volunteers used each for 1 month with a 1 month washout period between devices. Those with systolic blood pressure over 120 had lower blood pressure measurement while using the high-efficiency particulate air filters. The authors conclude that air purifiers have a clinically important beneficial effect on blood pressure in hypertensive people living near highways.
A study published in the Mayo Clinic Proceedings evaluated the link between cardiorespiratory fitness and the development of colorectal cancer. The research involved more than 600,000 U.S. military veterans over 10 years who had all taken an exercise treadmill test. People who were more fit based on the test results were less likely to develop this common cancer. Compared with the least fit individuals, the risk of cancer dropped by 14% in the next category up and by 57% for those who were most fit. To get fit, people need to engage in moderate intensity physical activity, such as brisk walking. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Cancer treatment can be grueling. Repeated rounds of chemotherapy or radiation, sometimes both, can leave a person feeling exhausted and utterly depleted. Going for a walk or a swim may be the last thing cancer patients feel like doing.
And yet, increasingly, research tells us that is exactly the right step to take. A recent study published in the Mayo Clinic Proceedings showed that people who exercise regularly are less likely to develop colorectal cancer. But today, we are talking about an astonishing study showing that a personalized exercise program can play a critical role in treating colorectal cancer.
Our guest is Dr. Christopher Booth. He's a medical oncologist and health services researcher at Queen's University in Kingston, Ontario, Canada. He's director of the CCE division of the Queen's Cancer Research Institute and a clinician scientist in the Cancer Center of Southeastern Ontario. Dr. Booth is also a professor in the departments of oncology and medicine at Queen's University.
Welcome to the People's Pharmacy, Dr. Christopher Booth.
Good day. Thank you, Terry and Joe, for inviting me on the show.
Dr. Booth, you're an oncologist. I've always thought of oncology as one of the most challenging specialties in medicine. We were absolutely blown away by your study that colleagues published in the New England Journal of Medicine last June. Before you tell us the results, though, kind of give us the backstory. What prompted this research?
Thanks, Joe. I may be biased, but I think it's a pretty interesting backstory. As with many of these projects and studies, sometimes the story behind the results are just as interesting as the results themselves. So this was a long project. In fact, pardon the pun, but this was a marathon of a clinical trial. It dates back almost 20 years. So I am a medical oncologist and a health services researcher. And in 2006, 2007, I had finished my clinical training, so I was fully qualified as an oncologist, but I was doing 2 years of advanced research methods training with the Canadian Cancer Trials Group, which is our national cooperative trials group that runs cancer clinical trials both in Canada but all over the world. There's a number of similar groups in the United States and most countries worldwide. So I was here at Queen's University at the Canadian Trials Group as a research fellow, learning how to run, design, and analyze trials. But I was a young cancer doctor interested in colon cancer. And I also happened to be a former varsity long-distance runner. I ran cross-country and track through my undergraduate years and even through medical school. So it was kind of an interesting convergence of being a cancer doctor, being a clinical trials fellow, and being a runner that led to, what subsequently has transpired over the next really almost 20 years. So in fact, the first draft of the protocol for this study, I wrote in 2007 as a class assignment. I was taking a graduate course in epidemiology at the time during my fellowship. The title of the course was Principles of Clinical Trials. And there was no exam, there was no midterm, there was just one course assignment, and you had to write a phase 3 clinical trial protocol. And in fact, the study that I wrote was what became the CO21 challenge trial. And so the reason, or the way this whole thing got launched was the Canadian Cancer Trials Group had a number of experts involved in an idea of running a clinical trial to see if exercise could improve fatigue from chemotherapy. And I happened to be sitting in a room, probably a dreary hotel room, listening to this kind of concept. And there was a lot of interest and excitement because, as you can imagine, most of the studies we do in oncology relate to chemotherapy or other cancer drugs or radiation and surgery. So there was general interest in exploring exercise. And it was a study of about 200 people to see if we could improve the fatigue that people commonly get on chemotherapy. It was still in the early kind of discussion or design phase. But 2 or 3 months earlier, as a young whippersnapper, I had read some papers published in major journals by oncologists, actually in the United States, that had used observational data sets. So these were data sets collected really from a number of thousands of nurses and physicians who had contributed data over many years. And these data sets suggested that the amount of exercise people did after their cancer diagnosis, specifically in colon cancer and breast cancer, appeared to be related to improve survival. So, of course, this was not a randomized trial. It was observational data. People who exercise might be very different in a number of ways from people who don't exercise. So it's hard to know what was driving the apparently improved survival. And so I was young and naive enough that at this meeting in the hotel room, I put up my arm and I said to a number of esteemed colleagues, I think if we do a clinical trial of exercise for chemotherapy fatigue, it'll probably work. People's fatigue will get better. They'll feel better. But I'm not convinced this will light the world on fire and change practice and policy. I think we should aim higher, and we should try to see if exercise can improve cancer survival. And again, I'm sure a number of people rolled their eyes or shook their head because this is 20 years ago. I was very junior and probably naive, but based on this pretty compelling data, I had this idea and I started pitching it and pushing. And early on, I realized that while I knew something about chemotherapy and cancer trials, and I was an athlete and believed in exercise, I was not an exercise scientist or a behavior change expert. And that's where very early on, I partnered with my study co-chair, Professor Carrie Cornier from the University of Alberta, who's a kinesiologist who has spent decades running smaller clinical trials of lifestyle interventions in people with cancer to see how to best improve their physical activity and exercise. So that's a little bit of the backstory. And from that, we started pitching the idea to our National Cooperative Trials Group. And sure enough, it was approved in 2008. And in 2009, we put the first patient on the challenge trial. And this was the first clinical trial in the world asking if exercise can improve cancer survival. So that's a bit of a long-winded answer, but that's, I guess, the backstory to how this all got started.
Well, I am astonished, actually, that something that you did as a graduate student in 2007 was actually already starting in 2009. That sounds like lightning speed to me.
Things did move pretty quickly. I was very, very fortunate that, this was a unique idea. The patient community and patient advocates loved the idea for a number of reasons, and I'll circle back to that in a moment. And I was very lucky that there was enough senior people and decision makers and leaders in the Canadian Cancer Trials Group and the Canadian Cancer Society who ultimately funded the trial in Canada, that they were willing to take a risk on a really bold, ambitious, an idea that at the time was way out of left field. So I was, very fortunate in that regards, and people were willing to say, you know what, no one else is going to do this. Let's see if we can be the ones to try to answer this question. And the reason I say that the patients and patient advocates were strongly in favor of this is, as an oncologist, one of the most common questions that we get asked when someone finishes chemotherapy is, Doc, what else can I do to improve my chances? And for decades, once they finish standard treatment, we haven't really had any good advice. And so this was a topic that we knew is empowering for patients. They were looking for answers in this space. And, the time was right to really test it with a clinical trial.
Well, I am so glad that you told us why the patients and the patient advocates were so excited about it. And now I hope you'll tell us about the trial. How was it designed?
So, Terry, the trial was designed using a randomized control trial design where we enrolled patients with colon cancer. It was stage 2 and stage 3 colon cancer, patients with, locally advanced but potentially curable disease. Standard treatment for those patients is to receive surgery and then between 3 and 6 months of chemotherapy afterwards. And then the usual practice is you follow those patients for several years with periodic blood tests and colonoscopies and CT scans. And essentially, you cross your fingers and hope the disease does not relapse. We know from experience that unfortunately, 30 to 40% of patients will have a recurrence of their disease. And usually, when it recurs, it's not curable. So, this was a patient population that was clearly at very high risk with an unmet need for more treatments to help improve their outcomes. So the study enrolled patients with colon cancer who had had surgery, who completed chemotherapy, and they were randomized to the control group, in which those patients received an informational booklet encouraging a healthy diet and exercise, or the experimental group. And those patients received the same booklet, which essentially was a booklet of advice. But the really innovative part here was the patients in the experimental arm received a funded physical activity consultant for 3 years to work with them to change their behavior and their lifestyle and gradually ramp up their exercise over the first 6 months and then sustain that change in lifestyle over the subsequent 3 years.
So this was like a personal trainer.
Essentially, the trial gave half of the patients a funded personal trainer and life coach for 3 years.
And the envelope, please, because this is such a powerful study. We need to know what happened.
So the personal trainer worked with patients, and again, this trial was run 889 patients across 55 hospitals in 6 countries. Most of the patients came from Canada and Australia. The personal trainer met with the patient every 2 weeks for the first 6 months as they ramped up their exercise. In the next 6 months, they continued to meet every 2 weeks. And then in year 2 and year 3, it was monthly check-ins to sustain that lifestyle change. So in the first year, it was pretty intense. And in those 1-hour meetings, the first half would be a coaching, motivation, goal-setting session. And the second half would be a supervised exercise session, usually on a bike or a treadmill. What did patients do for their exercise? Well, their target was to increase their exercise by something called 10 MET hours per week above baseline. What is a MET? It's a unit of energy expenditure. And the 3 of us, if we chat now for an hour, will spend 1 MET over that hour. But if we were to meet in real life and to go for a brisk walk for 1 hour, that would count for 4 METs. And so patients could come up with an exercise prescription together with their trainer that took into account their lifestyle, what kind of aerobic exercise they like to do, and how many minutes of various intensities were required, whether it was swimming, biking, walking, running, kayaking, cross-country skiing. We had patients do all sorts of things, but the most common regimen for patients was a walking routine where they would walk between 45 and 60 minutes at a brisk pace 3 to 4 times per week. And that would allow most patients to meet their targets.
Now, Dr. Booth, we are going to take a break. When we come back, we're going to find out what the results of your study produced.
You're listening to Dr. Christopher Booth. He's a medical oncologist and health services researcher at Queen's University in Kingston, Ontario.
It's time for a break. Coming up next, you can learn about the results of Dr. Booth's study.
We'll geek out with the NNT for exercise. It's pretty amazing. How does it compare to chemo?
What kinds of exercise did volunteers perform?
You're listening to The People's Pharmacy with Joe and Terry Graydon. This podcast is brought to you in part by Sonu.
Ready to breathe like never before? Meet Sonu, S-O-N-U, the world's first FDA-approved wearable headband that gives you drug-free relief from nasal congestion in minutes. It's safe for adults and kids 12 and up, making it perfect for families dealing with allergies, sinus issues, or chronic stuffiness.
Sonu uses personalized sound-based therapy to naturally open nasal passages. No meds, no steroids, no sprays. Even better, up to 4 users can share one account, so the whole household can benefit. compatible with both Apple and Android smartphones.
Learn more at getsonu.com. That's GET, get, SONU, sonu.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Grayton. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, using sound instead of steroids. More at getsonu.com. That's GETSONU.com.
We're talking about exercise as powerful cancer medicine. How does a personalized exercise program compare to traditional cancer therapy when it comes to something critical like survival? What kinds of exercise are helpful? Can cancer patients really stick with an exercise program?
We're talking with Dr. Christopher Booth. He's a medical oncologist and health services researcher at Queen's University in Kingston, Ontario, Canada. He's director of the Cancer Care and Epidemiology Division of the Queen's Cancer Research Institute and a clinician scientist in the Cancer Centre of Southeastern Ontario. Dr. Booth is Canada Research Chair in Population Cancer Care.
Dr. Booth, you've been telling us about your randomized controlled trial comparing exercise to what doctors usually do, which is tell their patients, you should exercise, it's good for you, and just let them figure it out for themselves. And the program that you were testing provided very structured and intensive personal trainer type guidance to the people who were in the intervention group. Now, this was over 400 people, right? How many of them actually kept exercising?
Yes, Terry. So there was well over 400 people in each of the two arms. So the total trial population was 889 patients. Half were on the control group and got the booklet, and the other half had the personal trainer. So what's interesting, Terry, is, in some ways this research study was asking two questions, and you had to answer question one before you could go on to the ultimate question two, which is, will exercise improve cancer survival? Question one was, if you give patients who have had surgery and chemotherapy for cancer, if you give them a funded personal trainer for 3 years, will they change their life exercise levels? And so at the beginning, after the first 200 patients were on study, we actually had to do a formal interim analysis to see, did the exercise curve separate? Because if they didn't, you could really just stop the study, because it's impossible to imagine you'd see a survival benefit if there's no difference in exercise. And in fact, what we saw was exactly what we might have predicted in those early analyses. We saw that both groups of patients increased their exercise. Of course, there was nothing preventing patients on the control arm from exercising. These were motivated patients. They received the booklet. They noticed an increase in their exercise levels, but the patients in the experimental group had a far greater sustained change in their physical activity. So that was the first very early signal that was encouraging. So fast forward now 15 years of patients going on this study, and in early 2025, we got the final results. And so of these 889 patients, we saw that those on the exercise arm, as we expected, clearly increased their exercise levels, and not just self-reported exercise levels. When we did objective physiologic measures of their fitness, including VO2 max testing and putting them on a treadmill for a walk test, we saw that there was objective improvements in their fitness compared to the patients who received the informational booklet. And we also found their quality of life and their ability to function physically improved. But the real excitement was related to the study primary endpoint, which was, could we improve disease-free survival? And that was a composite of death, recurrent disease, or developing a new cancer. And we found a substantial and meaningful reduction in the risk of recurrent disease or new primary cancer. So patients on the exercise arm had a 28% reduction in the risk of recurrent or new cancer. And to put this in an absolute term, if we look at 5 years at the proportion of patients who were alive and free of cancer, it was 74% in the control group and 80% in the experimental group with the exercise program. So this was an improvement of 6%. And another way of putting that number into context is that for every 16 patients who went on the exercise program, exercise prevented one person from developing new or recurrent cancer. So it was a very exciting result. And in fact, that magnitude of benefit is comparable to many of our standard, very good chemotherapy drugs that we use every day. So it was an impressive and very, very exciting finding.
Well, what you're suggesting is the number needed to treat that Joe and I have talked about occasionally over the years. Not everybody really gets it, but the number needed to treat was 16. That's not very many. That's a great number needed to treat.
Exactly.
How do your cancer chemotherapies compare?
Exactly. I mean, some of them are comparable, some of them are better, but some of them are smaller than that. And the other unique thing, Terry, is, the number needed to treat of 16 means that of those 16 people, one person is able to prevent future recurrence or cancer. But unlike every other form of cancer therapy, the risk benefit ratio of exercise here is totally different. So even amongst those 16 people, the other 15 people will all, of course, benefit from the numerous other things that exercise can do. I should mention that, like every clinical trial, we were interested to see whether there was any sign or signal of safety, concerns, side effects, or toxicity. And the only signal that emerged was a modest increase in the risk of musculoskeletal injuries associated with exercise. So this is not without risk, but clearly the numerous other benefits of exercise will be realized by all patients who go on this program. The next part of the results, Terry and Joe, that were, equally astounding and very, very exciting was when we looked at overall survival. So mortality, when we looked at, the proportion of patients who were alive, and we had a lot of follow-up. The median follow-up here was 8 years. So we followed these patients for a very long time. And there was a 37% reduction in the risk of death from the exercise program. And again, at 8 years, 83% of patients in the control group were alive, compared to 90% of patients on the exercise program. So the number needed to treat is 14, meaning that for every 14 patients who go on the exercise program, exercise will prevent one person from dying. So really a very exciting result. And I guess the last comment I'll make about the survival data was, a very logical question would be, well, is the exercise actually preventing deaths from cancer? Or is it preventing deaths from diabetes, heart, stroke, obesity, etc.? And what we
Mm-hmm.
found very clearly was that this difference in survival is driven by a reduction in the risk of death from colon cancer. So the exercise intervention is clearly doing something to these micrometastatic cancer cells that are often hiding in patients' bodies after surgery and chemotherapy. Exercise is inducing physiologic, hormonal, inflammatory, immunologic changes in the body that are helping the body eradicate a proportion of these cancer cells.
Well, that was where I was headed next because as a pharmacologist, I love mechanism of action. And it sounds like even though you haven't nailed it down yet, exercise produced clear physiological responses, and you might even be able to speculate what that mechanism of action to reduce the risk of recurrence or improve mortality might have been. What are your thoughts?
Great question, Joe. And so what I can tell you is that when we launched the trial in 2008, 2009, there was a number of observational data sets suggesting an association. And there was also emerging data from the lab showing that cancer cells in a petri dish, when you induced kind of physiologic changes of exercise in models, appeared to have some kind of anti-cancer properties. Fast forward now, during the 15 years the trial was running, and there's been growing and more observational data to support this and greater data from the lab to suggest that exercise probably has a number of mechanisms of action, including improving the immune function in patients, changing of inflammatory markers, changing of the metabolic pathway. One of the areas of great interest is whether the effects of exercise on insulin and insulin-like growth factor, which can turn cancer cells on or off, and of course, changes in vascular physiology. We, at this point, don't have one specific answer. There's a number of mechanisms that are likely at play. So unlike our drugs, which typically have a single mechanism of action, it is very likely that exercise has multiple mechanisms of action. But what I can tell you, Joe, is that as part of the trial, we banked blood on all 900 patients at multiple time points during the study protocol. And so over the next couple of years, we'll be investigating those blood specimens to try to better understand how is it biologically that exercise is improving cancer survival.
Well, that will also be very interesting, but already the results are so, I mean, the most important result is that people survive longer if they are offered this opportunity to really get into their exercise. And please review for us again, what sorts of exercises were people doing? You said it was an individual prescription for each person.
Correct. So it was aerobic exercise, and they had to hit this physiologic measure of 10 med hours per week, an increase above baseline. And so that could be jogging 25 or 30 minutes at a time, 3 to 4 times a week. It could be going for a walk briskly at a brisk pace, so huffing and puffing. As my co-chair, Professor Cornier, said, if you're going to be walking, you have to be walking fast enough that someone thinks you're either late for an appointment or you just robbed a bank. This is a commitment.
Okay.
This is a
Good.
commitment. You need to be out there hoofing it a bit. But again, this was gradually ramped up over those first 6 months. But we had patients who were swimming, who were biking, kayaking, cross-country skiing. But the vast majority of patients went on an exercise program. And the reason I think this is important to emphasize is that, undertaking a new exercise program and sustaining it is not easy. It takes time, it takes dedication, perseverance. It can be very difficult for many patients and all of us in society with busy lives and family and work commitments. So this is a commitment, but it's achievable for patients. We were not expecting them to train for a triathlon or run a marathon. It's a commitment, but the intervention is empowering for patients. It gives them some sense of control on their own health and outcomes, and it's achievable to targets. The other part, of course, which I'm sure we'll talk about from an implementation and policy point of view, is this is very affordable for health systems. So, we live now in an era where most of my new cancer drugs, whether they're chemotherapy or immunotherapy drugs, cost between $100 or $150 or even $200,000 per year. So these are very, very expensive treatments. The total estimated cost of having a personal trainer meet with someone every 2 weeks for a year, and then once a month for year 2 and year 3, it's in the range of $3,000 to $5,000 over those 3 years. So it does require an investment by health systems, hospitals, insurance companies, and patients. But certainly, we're doing a formal cost effectiveness analysis now. But this is something that is likely to be highly sustainable for health systems. In fact, by improving health and reducing recurrences and new cancers, this is likely able to save the health system funds to use in other elements of healthcare.
That is a dramatically different cost.
It is. It is. One of my colleagues has joked, first of all, if we called this treatment exercisumab,
Hmm.
and it costed, $200,000 and had this benefit, but made people very sick, it would immediately be in all of our clinical practice guidelines. And within weeks or months, it would be given in major hospitals all over health systems in the world. It would be funded. And so we need to, as a community, really advocate for this to be taken seriously and implemented and rolled out. Because as my colleague would say, he said, Chris, the cost of exercisumab is a rounding error when it comes to the budget for our monthly chemotherapy treatments.
Now, what's the barrier then for actually getting structured exercise programs funded?
Well, let's hold on to that
Okay.
and come back to it because I want to ask you first, Dr. Booth, what about other cancers? And I'll just tell you a brief story. My best friend, Dr. Tom Ferguson, he was a physician. He, in essence, was the father of the medical self-care movement in the United States and to a certain extent around the world. He was diagnosed with multiple myeloma a couple decades ago. And Tom was a great believer in exercise, and he even brought his exercise bicycle into his hospital room when he was treated first at not at MD Anderson. Yeah,
Yes,
it
it
was
was.
MD Anderson, and then at University of Arkansas. And the doctors wanted to know, why are you bringing your exercise bike in here to your recovery room? You're going to be exhausted. He said, no, 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 no. I think exercise is going to be really important for my recovery. And in fact, he lived much, much longer than most of his oncologists expected him to, many years beyond the normal amount in those days. And so I kind of wonder, what about other cancers, whether it's multiple myeloma, a blood cancer, or breast cancer, or fill in the blank?
Great question, Joe. And so I think this is one of the really interesting kind of translational pieces about as we move from evidence into practice, and also, what the research environment will look like in the coming years. What I can tell you is that there's two clinical trials testing exercise in ovarian cancer, and those results will come out in the next number of months. So that's very exciting. There's also a very large trial in breast cancer in the United States testing a diet and nutrition intervention that also includes some exercise guidance as well. So there's more activity coming in this space, so stay tuned. But within our study, clearly the results are most applicable to colon cancer patients with stage 2 and stage 3 disease. And I think as of now, that's a new standard of care for those diseases. What we found also, Terry and Joe, was when we looked at the types of cancers that were being prevented, because remember, these patients, we had 900 of them, they were being followed for a long time. And so some of them got other new cancers. And so we saw hints in the data. There was a marked reduction in the risk of new breast cancer in the patients on the exercise program, as well as prostate cancer in the exercise program. So those are early hints that suggest that perhaps exercise has activity in other cancers. And in fact, the observational data in those diseases is also very strong. So I think it likely that exercise has benefits in other cancer contexts. The extent to which that's going to make it into guidelines and practice recommendations, I think, is an issue that our field will need to discuss. And I think there's going to be ongoing research to help further define this in other cancers. But at the end of the day, as we talked about with the risk-benefit ratio of exercise, I think it would be very reasonable for all of us, whether we have cancer or not, to consider talking to our oncologist and an exercise specialist about a new fitness program.
We just have about a minute and a half left before our break, but I'm curious, your colleagues, have they been jumping up and down for joy? Are they excited? Have you been, the superstar of colorectal cancer oncology?
I wouldn't say it's a superstar, but what I can say is this study has exploded in both the public space, in media. I think it's been in 300 or 400 newspapers. It's been in the New York Times, BBC. It's been all over the world. And there's been tremendous interest from oncologists, researchers, and most importantly, patients and their families. And so there has been a huge amount of interest. I think the next big piece, and I'm sure we'll get into this, is how are we going to turn this into routine practice and policy?
That is absolutely where we want to go next. And we also want to talk about affordability, because you've pointed out it's dramatic. I mean, $200,000, $300,000, $500,000, not unusual. And exercise is a pittance, but getting people to pay for it, that's the challenge. We'll find out about where we go next when we come back after this break.
You're listening to Dr. Christopher Booth. He's a medical oncologist and health services researcher at Queen's University in Kingston, Ontario. He is Canada Research Chair in Population Cancer Care.
It's time for a short break. How did Dr. Booth motivate the volunteers in his study to really get out there and exercise?
Healthcare systems seem reluctant to pay for health coaching to encourage people to exercise if they have cancer. Is there a way that might change?
Insurance companies pay for cardiac rehab, and most cardiologists recommend it to all their heart patients. Why not cancer rehab?
Does exercise help prevent cancer?
Find out what Dr. Booth's amazing research could teach all of us.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, using sound instead of steroids. More at getsonu.com. That's getsonu.com.
We've all heard that exercise is good for our health. But that seems rather abstract. When someone gets a cancer diagnosis, life changes. It often leads to challenging treatments and trepidation. Exercise often seems like a good idea, but hardly essential.
However, there is increasing evidence that exercise makes a big difference in the outcome of cancer treatment. In other words, it's not a luxury. Rather, it's a crucial component of cancer care.
We're learning how exercise can help cancer patients survive and thrive. Our guest is one of the world's foremost authorities on exercise and cancer outcomes, especially when it comes to colorectal cancer. Dr. Christopher Booth is a medical oncologist and health services researcher at Queen's University in Kingston, Ontario, Canada. He's director of the Cancer Care and Epidemiology Division of the Queen's Cancer Research Institute and a clinician scientist in the Cancer Centre of Southeastern Ontario. Dr. Booth is also a professor in the Departments of Oncology and Medicine at Queen's University and Canada Research Chair in Population Cancer Care.
Dr. Booth, in the past, when we have very occasionally talked to physicians about exercise for people with cancer, they frequently say, it's really hard to get people to exercise. They're fatigued. They don't want to move. They're psychologically overwhelmed. How did you motivate the people who volunteered for your study? How did your participants get themselves out there to meet with their personal trainers?
It's a great question, Terry. And getting patients to change their lifestyle can be difficult at any point, but especially when someone's dealing with the emotional and physical consequences of a diagnosis of cancer. And certainly patients with a very advanced or incurable disease or patients on active chemotherapy, it might be very difficult for them to make major changes in their lifestyle. And so we are quite specific in the way that we designed the trial. These patients had already completed surgery, they completed chemotherapy, and we had a washout period. They could only go on the study between 2 and 6 months after their last dose of chemotherapy. So the patients had recovered largely from their cancer treatment, but you're right, it was a major commitment for them. And so these patients were motivated. They volunteered to go on a research trial that was going to make them exercise or encourage them to exercise, and also subject them to a lot of extra tests and visits. So it did take some motivating, but I think what really drove this was the behavior change intervention and this relationship with the personal trainer. And so my co-chair, Dr. Cornier, really had developed this over many, many years, this hybrid model of including both supervised exercise sessions with the human connection and rapport building of a motivational coaching session. And I've heard very powerful stories from some of my own patients that went on this clinical trial of the relationship that they developed with their physical activity consultant. They felt accountable to this person. They did not want to let that person down. They were motivated to exercise so that when they came in every 2 weeks, they could review progress and make plans for the next 2 weeks. So certainly motivating people is the first part of this. And as I'm sure we'll talk about, simply telling someone to exercise will be insufficient to allow most people to realize these benefits. In fact, that's what the trial showed, right? The control group was essentially told, go exercise, and some of them did. But when you gave them this life trainer and the behavior change program, it led to a major difference in their lifestyle.
So, Dr. Booth, as you pointed out, the personal trainer aspect of it and the motivational coaching, this is critical, and it's not free. You need to reimburse the personal trainer for the amount of time that they're putting in. So it doesn't cost as much as a high-powered something UMAB, but it does cost some money. And up until now, we have not seen that healthcare systems, at least not in the U.S., have been willing to pay for exercise coaching. Do you think that there is going to be a way that that will change and this exercise approach will become routine policy?
Terry, I think so. I mean, I'm an optimist, but I hope that this clinical trial will be an impetus for the health system to start making some of these changes. I think, if we take a step back, I don't think we can afford to not do this. I mean, we routinely spend hundreds of thousands of dollars on drugs that help some people but make people really, really sick. And we have an intervention here that is very effective with minimal side effects that cost a few $1,000s. So I think the economic argument can be made, especially this will probably save the health system money and certainly can improve the lives and improve survival of patients. The tricky part is going to be, what does this model look like? And so I would like to imagine a future in which, when a patient is diagnosed with cancer, the health system, the payer, the insurance company, the hospital, the Ministry of Health, depending on where the patient lives, clearly provides a surgeon and pays for the surgery to happen for that cancer. That patient then gets referred to see me or my colleagues as an oncologist, and their chemotherapy drugs are paid for by the system. And I would like to imagine a day where, when they finish chemotherapy with me, I can refer them to my colleague, an exercise specialist at the cancer center, who will then work with that patient in the coming months and years to help them change their lifestyle. And we do have precedent for different phenotypes being part of the cancer system. We have dietitians, we have social workers, we have speech language pathologists, we have psychologists. So there is a model where we have these people on staff and they're funded by the health system. And so I paradigm whereby an exercise specialist, whether it's a kinesiologist, physical therapist, personal trainer, there can be a number of different models where that person is embedded as part of routine care in the cancer system.
Well, Dr. Booth, you live in Canada. You do your research and treat patients there, where you have what some people would call a civilized healthcare system. Here in the U.S., we have to rely on a kind of a patchwork. We spend more than any other country in the world, but our results are substantially lower. I'd like to compare what you are sort of creating and suggesting and dreaming about. We have already implemented when it comes to heart attacks. If a patient in the United States has a bad heart attack, even a modest one, almost inevitably they are going to be referred to cardiac rehab. And so insurance companies get this automatically, and they say, well, of course, it would be beneficial if, after your heart attack and after your stent and all the other things that we have done, that we refer you and pay for cardiac rehabilitation.
And I think for older Americans, I think Medicare pays for cardiac rehab. I'm not certain.
I believe it does. And so the bottom line is, we have a system, if it comes down to it, for heart attacks or heart disease. Why couldn't we adopt something similar, adding in that personal trainer piece, for cancer patients, especially colorectal, since we have now your data? We already have an idea for following up on what you're proposing.
Joe, I think that's a great idea. In fact, we've had similar discussions here in Canada. We also have a cardiac rehab model. And we've been discussing, even though we just published this data 4 weeks ago, there's been numerous discussions with ministries of health and payers, both here in Canada and countries worldwide. People are pretty keen to implement this. And so it's trying to figure out what that looks like. And the cardiac rehab model shows us that we can do this within the quote unquote traditional health system. So I think there needs to be a commitment to doing this. And I think that the patient voice and patient advocates and oncologists will be a big part of trying to drive this forward with our policymakers and the payers.
Dr. Booth, I am wondering now, you have demonstrated that exercise, structured exercise, can be an important part of the cancer treatment, of the treatment program for people with colorectal cancer. And I'm thinking, well, I'm hoping I'll never be a patient with colorectal cancer, but there might be a message here for me. Does exercise help prevent cancer?
Great question, Terry. And I think most of us would believe, yes, it does. In fact, there is compelling data that people who exercise have a lower rate of developing cancer in the first place. And even within the challenge trial, there was a pretty strong hint of that, right? When we followed these patients, we found a clear reduction in the number of new breast cancers, new prostate cancers, and in fact, new colorectal cancers. So I think that even beyond cancer, there's obviously many reasons for us all to exercise, including emotional wellness, mental health, and just overall fitness. But when it comes to cancer prevention and certainly preventing other chronic conditions like diabetes, obesity, cardiovascular disease, there's going to be a multitude of reasons for all of us to get moving and undertake an exercise program.
Dr. Booth, I'd like to go back for a moment and talk about the number needed to treat, because I think a lot of people, their eyes glaze over when you say, yes, the NNT was 14 when it comes to mortality, or 16 when it comes to a recurrence of the colorectal cancer. We often talk about statin-type cholesterol-lowering drugs here on the People's Pharmacy, and we have asked, cardiologists, well, what's the number needed to treat when it comes to taking the world's favorite statin, atorvastatin, and that was originally sold under the brand name Lipitor, and there was this very widespread commercial in magazines in which it said you could lower your risk of having another heart attack by 36%, which, big headline, seemed so impressive, but there was an asterisk after that, and it said, at the bottom of the page in small print, if 100 people took atorvastatin, Lipitor, for 5 years, there would be 2 heart attacks. And if you took placebo for 5 years, there'd be 3 heart attacks. So you could, 1 person out of 100 could avoid a heart attack by taking Lipitor for 5 years if they were high risk. And I think the number needed to treat was,
over 50.
Over 50, maybe up around 70. So your NNT, your number needed to treat at 14 for mortality or 16 for recurrence is stunning. So much better. And the cost, remind us, the cost was teeny tiny.
Yeah, absolutely. It's in the range of $3,000 to $5,000 over 3 years. You're absolutely right, Joe. So to put this in context, I mean, some of our good cancer treatments would improve absolute overall survival by, 10 or 20%. Okay, so those are some of our really good ones. So that's a number needed to treat of, 5 or 10. So we do have these, but we also have a lot of drugs that are standard of care that cost $200,000 that improve overall survival by maybe 2% or 3% or 1%. So those are number needed to treat of 30, 40, 50. So you're right, with a number needed to treat of 14, the risk-benefit ratio of exercise is really quite remarkable.
If we put you in charge, and we would love to of the Canadian healthcare system, what would you do?
Well, I think what's going to happen, and I'm sure this already is happening, is some patients will hear about this, their doctors will talk to them about that, and they will begin to exercise. And those with financial means will go to a gym and get a personal trainer to help them design this type of intervention. But if we really want to improve public health and ensure that all patients have access to this regardless of their financial situation, we need to embed an exercise program as routine standard of care in the cancer system that is paid for by insurance companies, ministries of health, payers, etc. And so I would like to see a scenario where that is a standard component of care, where just like I can refer to my colleagues in surgery, radiation oncology, speech therapy, dietitian, we have an exercise specialist on staff at the cancer center. And you're right, maybe it looks like a cardiac rehab program where I refer them, whether it's a cancer center or an adjacent facility. We're going to have to be flexible, whether people do exercises at a local gym or at the university or at the hospital or at home. All of that can be sorted out based on local context, but I think that's the vision that we would like to see.
And Dr. Booth, if we had unlimited funds here at the People's Pharmacy, we would bring you to the United States and have you present to every oncology group that we could possibly find. What would you tell your oncology colleagues, whether they are specialists in colorectal cancer or breast cancer or prostate cancer or fill-in-the-blank cancer?
I would tell them that, this is something that they and their patients have probably been wondering about and looking for years. And we now have very strong data that we have an intervention that is empowering for patients, it's achievable for patients, it's sustainable for the health system, and it helps people live longer and better lives. And that we need to advocate for it, and that exercise is no longer just an intervention that improves quality of life and fitness. It improves cancer survival, and we really need to advocate for it to become part of standard care.
Dr. Booth, in our remaining minute, what should the rest of us take away from your research?
I think this just speaks to, the power of the human body and the ability of exercise to help all of us live a better life. We feel better, our mental health improves, and our physical function improves. And for many of us, it likely has many health benefits to prevent other chronic diseases in the future. So I think it's maybe a signal that we probably have more agency over our health than we often think we do. And obviously, this exercise program in the context of colon cancer, together with surgery and chemotherapy, a structured exercise program over 3 years, can certainly make a big difference in outcomes for patients.
Dr. Christopher Booth, thank you so much for talking with us on the People's Pharmacy today.
You're very welcome. Thanks for having me on the show.
You've been listening to Dr. Christopher Booth. He's a medical oncologist and health services researcher at Queen's University in Kingston, Ontario. He's director of the Cancer Care and Epidemiology Division of the Queen's Cancer Research Institute and a clinician scientist in the Cancer Centre of Southeastern Ontario. Dr. Booth is a professor in the Departments of Oncology and Medicine at Queen's University and Canada Research Chair in Population Cancer Care.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and sinus pressure, using sound instead of steroids. More at getsonu.com. That's GETSONU.com.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
Today's show is number 1441. You can find it online at peoplespharmacy.com. That's where you can share your comments about today's interview. We'd love to hear from you about your own experience with exercise. How have you incorporated physical activity into your life? In the show notes, we've included a link to Dr. Christopher Booth's research so you can see the study for yourself. You can also reach us through email, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider. You'll find the podcast on our website on Monday morning.
At peoplespharmacy.com, you could sign up for our free online newsletter and get the latest news about important health stories. When you subscribe, you also get regular access to information about our weekly podcast. That way, you can find out ahead of time what topics we'll be covering. Speaking of the podcast, we'd be grateful if you would consider writing a review of the People's Pharmacy and posting it to the podcast platform you prefer. That helps other people find it.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you so much for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.